Hi. Is this on?
Grab iPad number 2 to turn that on. Try it now.
Good morning. Good to see you. It's always, I was telling Pastor Melissa when I came in, it is always good to be in this place. This place is full of the warmth and the love and the gentleness of the Holy Spirit. I love being here, and I'm so grateful to be here this morning with Ken Connelly, the Vice President of Operations at Lutheran Social Ministries of Maryland, our parent organization to both Carroll Lutheran Village and the Lutheran Village at Miller's Strand. He will be presenting this morning a seminar called Dementia and Caregiving. It will cover four major topics, and he will describe those to you. But I know this is part of, or at least the kickoff, again, hopefully, to a series of seminars that Ann Boyle so faithfully brought to you pre-COVID. And we all, we're still talking about those pre-COVID times, which, let's face it, we'll never get back to. But some of those things that were happening pre-COVID are important to resurrect and to bring back. And Ann Boyles was so good to bring to this congregation issues of health and wellness. And so hopefully this is part of a kickoff to health and wellness presentations. And so we are so grateful to be here with you this morning. Thank you, Pastor Melissa and Ann, for welcoming us this morning. Here's Ken.
Thank you, Stacy. Everybody hear me okay? Yes. Good. Well, I wanted to thank everyone for coming. This is a topic or a discussion that is really near and dear for a couple reasons. Number one, I've been in the industry of senior living for over 25 years. And I started out as an activities director. And I remember, yes, way back when, being an activities director in a nursing home in Annandale, Virginia. Wow, that, back then it was you were senile, or they had different names for the residents that had dementia or Alzheimer's, and it was devastating to watch. And part of my job was when a resident would move into the nursing home, part of my job is to get their background and their history, and it was amazing, hard to watch the residents that were coming in with dementia. 5-star generals. Granted, Annandale, Virginia is close to the Pentagon, so there were a lot of retired military at that point. And 5-star generals, individuals that used to work for NASA, and they were coming in, they had dementia, or one of the dementias. It was awful. So throughout my career in senior care, boy, I've seen a lot of devastation with this disease. And I think we're getting closer to having more, interventions, management with dementia. Also, a big part of it is caregiving and making sure the caregiver is able to manage as well. So I'm going to talk about a few things today, very general, and happy to answer some questions as well. And I'll even have my phone number, my contact information as well to give out if you've got any more detailed questions. But really what I wanted to cover today are some of the main areas that we get a lot of questions about. Normal aging versus dementia, communicating with individuals with dementia, that's a big one. And also I think that, again, as I mentioned before, the ability to, as a caregiver, if you are taking care of a loved one with dementia, how important it is to make sure you're taking care of yourself. Because if you, as a caregiver, start to decline, then the situation gets even, it could evolve into a more complex situation. So I'd like to go ahead and get started with just, I get a lot of questions. I forgot my car keys. I can't find my wallet, which happened to me this morning. And you're sitting there and you're going, geez, do I have dementia? Now, I personally have had 5 concussions playing football. And so, is it possible I'm going to get dementia? Is it possible I'm starting to have it? Oh, sure. Hopefully not. But there's a lot of, you have a lot of things go through your mind. And as the population grows older and lives longer, we are seeing in our industry a lot more dementia. So with that brings a lot of questions. Am I getting dementia? Do I have dementia? But what I'd like to do is just kind of go over some of the key indicators. So normal aging, I'm going to list a few. This is on the first page. Normal aging, forgetting a name, leaving a pot on the stove, finding the right word. A lot of times, we're in a conversation, it's the end of the day, it's 7 o'clock at night, we've all been at work. Somebody asks you a question, you just can't find the right word because you're tired. Again, that's normal aging. Forgetting the day and the time. Again, that's normal. Misplacing keys and misplacing glasses. We've all done that many times. And feeling down or blue in a sad situation. Again, these are all normal things that everybody goes through. Now let's skip over to the right-hand side. Let's talk about dementia in these situations. So for an example, if an individual has dementia and you have a family member and you're at a function and they walk in and you forget their name, which is normal. We've all done that. The third cousin walks in. But if you forget they're a family member, I'd like to go back to the car keys. A good example of normal aging versus dementia is, again, we all lose our car keys. But individuals with dementia forget what the car keys do. That's the big one. And that's one of my favorite examples is actually forgetting what the car keys do. And I've seen and heard, losing car keys and then they're found and then the individual says, what are these? How do I use these? And they put them in the microwave. So that is one of my most favorite examples. Forgetting how to make a meal. Substituting an inappropriate word. Getting lost in your own neighborhood. These are all indicators that cognitively something may be going on versus normal aging. Placing a toaster in the freezer. Again, it goes back to this. It's the not having the ability to comprehend what certain items do. And then mood swings, personality changes. Often, that could be a sign of dementia. So there's a lot of different scenarios. And just because you forget your car keys, lose your wallet, lose your glasses, forget your lunch on the table before you go to work every day, that's normal. That's called being overwhelmed or late. And that happens. But some of these other ones that we just spoke about, these are the ones to keep an eye on. And again, I think the most important one is the key one, the car keys. Losing the car keys, okay. Not knowing what they do, big one. Let's go to the next one. Let's talk about more in-depth warning signs of dementia. So number one, memory loss. Short-term memory loss. Problems with language. So what does that mean? That would mean, again, word finding. That would mean having a conversation with someone, and for an example, having a conversation with Ann, and I say, Ann, I'm so glad to be here, but so glad to be at Trinity Lutheran Church. So have trouble finding those words. Disorientation. Disorientation in a normal setting, meaning the grocery store that you've been to for the past 30 years, you walk in, or an individual walks in, and they look over and say, where are we? Happens quite a bit. Impaired judgment. That's a big one with dementia. We talked about putting things in the microwave. Happens a lot. Judgment could be walking out the front door in the middle of a snowstorm, 25 degrees outside, walking outside. Happens quite often. My nephew is a Prince George's County police officer. He called me the other day. He said, would you come down and do some training with Prince George's County Police on dementia and how to communicate? I said, yeah, Zach, I could do my best. He goes, we have situations where we go into senior apartments and they're called over and over again for an individual that has gone to the wrong apartment, who has ended up in somebody else's apartment because they thought they were going into their apartment. And then the police come, of course, and, their first thing is somebody's broken into somebody's apartment, and that's not the case. But trying to redirect that individual to get them back is the important thing. But that's impaired judgment. You see that quite a bit. And again, mood, personality changes most frequently. Good day, wake up in the morning, have breakfast, go for a walk, and by lunchtime, an individual with dementia just want to sit on the couch, not do anything. Leave me alone. I don't want to do anything at this point. Just leave me alone. And then 4 o'clock, hey, let's go for a walk. So we see that we see this in dementia individuals and residents quite a bit. The mood changes, and then another big one is difficulty performing tasks. There's a lot of individuals with dementia that as the dementia progresses, things that they used to do was very, very easy to them is now very difficult. Paying bills, writing a check. A lot of people don't write checks anymore, but writing a check. What's this? How do I write this check? Taking out the trash. Where is the trash can? Oh, that's right, I remember. And again, these are things at first, these are indicators at first where you're thinking, okay, just maybe they're overwhelmed. But when these types of behaviors start to kind of pile up, and you're wondering if your loved one or a neighbor or someone that you're engaged with a lot, if you start to see these things more and more, it's a good warning sign that there could be some dementia. Let's go ahead to the next page. What causes? Let's talk about conditions that cause confusion and memory issues. Now, these are indicators, or these are items that can really cause confusion, not necessarily dementia. Especially if you're on a new medication. Somebody gets on a new medication. There's a lot of new medications out there, and sometimes it causes confusion. And you will see that eventually level out if somebody does not have dementia and it's strictly the medication. Eventually it'll stabilize, but it could, any medications can cause confusion or memory loss. Dehydration and not eating right is another one that causes dementia. I have seen hundreds of situations where I've seen patients that come from the hospital, and then they are in the hospital because they are weak and they are confused. Then they come to a senior living, nursing center, assisted living, and they come and they have 4 or 5 days of good meals. They're hydrated and they're ready to go. So dehydration and malnutrition is a big one. There's a lot of times where, as a neighbor, you don't, and I've again, this is a picture that's been painted for me quite a bit. Well, I haven't seen my neighbor in 4 or 5 days, or I don't see my neighbor a lot, and then when I do see my neighbor, she's very confused. And a lot of times what happens is that neighbor is basically not eating correctly. Dehydration. They live by themselves. So it's important to remember when you are talking to a caregiver, if you're the caregiver, or you're engaging in a conversation and somebody seems very confused, very, very out of it, it could be dehydration and not eating correctly. Also, depression can cause confusion and memory issues as well. The next one, infections. This is a big one. And this also goes back to dehydration. Infection. So there's an infection called a urinary tract infection. And a lot of times, if you are not hydrated, you get very, very confused. And you can get a urinary tract infection over a course of time by not properly dehydrating. So infections, that's a big one. And a lot of times, residents will come into a skilled nursing center, facility, and they're coming in off of the heels of having a really bad urinary tract infection because they weren't dehydrating, they became very weak, and now they're there to get back in shape, but it wasn't dementia, it was an infection. Confusion, a lot, hearing loss. A lot of people think that hearing loss, somebody that can't hear that well, automatically has dementia, which is not the case. Somebody has a tough time hearing. It just, they have a tough time hearing, not necessarily that they have dementia. But hearing loss is one of those big indicators that that's one you have to kind of look a little bit more into. Get them, obviously hearing aids or listening devices will clear that up. But these are again conditions that cause confusion and memory issues. Let's go ahead to the next page. So there's a lot of types of dementia. I'm not sure the exact number, but I think it's over 50 to 100 types of dementia. The most prominent one is Alzheimer's. That's the one you hear about the most. So let's talk a little bit about the top 5 that are most prominent that we are seeing in the healthcare industry. Alzheimer's. So what are some of the indicators for Alzheimer's? Short-term memory loss, decision-making, judgment. And also, with Alzheimer's, clinically, it's been defined as an individual that has plaques and tangles on your brain. So that is the most prominent type of dementia. Then there's vascular. Vascular dementia is another big one. Short-term memory is affected along with strokes, small strokes, TIAs they're called. And you may even know what TIA stands for. I forgot.
It is ischemic attacks.
That's it. Thank you. So, that is part of having vascular dementia. The next one is frontal temporal. And this is the type of dementia that affects the front of your brain, front lobe. And what does it do? How is it different from the other dementias? It really affects the behaviors and language. So when I say behaviors, somebody with frontal temporal dementia will behave in certain ways that they never did before. It's odd. It's out of character. We see a lot, unfortunately, with frontal temporal use of very, very bad language. Somebody that never used to curse or say anything even remotely to cursing. Now, with the frontal temporal, that changes. They will curse. Their language is definitely affected. Also, with frontal temporal, we're seeing a lot more diagnosis of individuals getting diagnosed earlier with frontal temporal. So when I say earlier, I've seen it throughout my career, 40s, 50s, 60s. And it affects people at different ages, but this one is one that is one of those dementias that you can start to get earlier in life. And it's one of those with frontal temporal. There are certain dementias that can last 8, 9, 10, 15 years sometimes, but unfortunately with frontal temporal dementia, it's very fast. It's a very fast decline clinically. And when I say fast decline, it means not only cognitively, but also physically. You will start to see a fast decline. There's also dementia related to Parkinson's. What goes along with that? Obviously, with Parkinson's, a lot of falls and muscle rigidity. Those are the ones that go along with Parkinson's. There's a lot of individuals, unfortunately, as they age with their Parkinson's, it does morph into dementia. Lewy body. Lewy body is another one that is being diagnosed quite a bit now. And with Lewy body, you will see individuals who are very, very paranoid, very skeptical. So for an example, and I think I did this at my last presentation, there's a resident at Carroll Lutheran Village when I go and sometimes walk around the unit or the area that we have our dementia residents in. There is a resident there. She thinks I work for the FBI. So she asked me a lot of questions, why I'm there. What are you going to do? Who are you there to see? Am I in trouble? I say, no, you're not in any kind of trouble. But she's definitely, and when you go and you look at her medical information, she has Lewy body dementia. So you'll see a lot of extreme paranoia. And I think also with Lewy body, sleep is also affected. Very, very much so. So these are the top 4 or 5, actually it's 5, dementias that are being diagnosed nowadays. And the good news is, I know for a fact, just in the past 10, 15 years, internal medicine and neurologists have really started partnering together more. And when I say partnering, they're starting to communicate more. So, for an example, you go to your internist and you haven't been eating well and you've got, you're diagnosed with a UTI, or you go to your internist and there's some other signs there. I think a while ago, maybe 20 years, 25 years and beyond, they probably would have just treated it with medication. But if you start coming back more and more with those types of illnesses on a regular basis, you're recommended to go to a neurologist, and the neurologist will do a battery of tests. And so there's a lot more diagnosing going on and early intervention by neurologists. So one of the things that is not on here is medications. And I think we get asked that a lot about medications. And I'll kind of branch off a little bit because I do know a little bit about the medications for dementia. And there are medications out there. There's a couple out there. And they are called cholinesterase inhibitors. So what that does is the medications that are out there now for dementia and Alzheimer's, I like to use the analogy of a parachute. They do not cure, but what they do, they slow the progression down. And they also help with behavior. So if we have an individual that has frontal temporal and they're started early on a certain medication for dementia, it will help them, but it is not the cure. It certainly is not the cure. Also see a lot where caregivers ask questions, my husband, my partner, whoever it may be that I'm caring for is really tough to handle. And they have Lewy body. So sometimes those medications, if you start them early, will have some benefits and help with the management of that individual. Help also with the day-to-day caregiving. So in terms of medication, I believe there's 3 or 4. And just know that they are a parachute. They are not a cure. And I know there's a lot of continued research that is happening for dementia to actually find some type of cure. I think it was 10, 12 years ago, there was some potential shot or a vaccine that they were trialing through the FDA, and I don't think it ever came to fruition. So it's not a cure. Let's go to the next page. We'll talk about communication with and dementia. This is very important as a caregiver or as an individual that is engaging with someone with dementia. These tips are very, very important. So approach. When you approach someone with dementia, your body language is very, very important. And when I say that, when you're walking into a house and you're greeting someone with dementia, the way you stand, the way you approach is so important. And you want to instill a very calming environment when you're speaking with someone with dementia and Alzheimer's. That's very, very important. Your eye contact is very important. I've seen a lot throughout my career where there's a resident with dementia and they're sitting at a table and one of the GNAs or CNAs comes behind them and starts talking to them. And that resident can't understand it. They don't know who they're speaking or who's trying to speak with them, and they get agitated, rightfully so. But getting in front and having that good eye contact is very, very important. Your speech, your cadence of your speech is also very, very important. Obviously, with someone with dementia or Alzheimer's, speak slow at a very moderate pace so they can understand you. Yelling, screaming, those types of things, it's just going to get the individual with dementia produce a very high level of anxiety. And like I said, your tone, your volume, slow, simple. Those are the types of approaches in terms of communicating that are very, very important. Some things what not to do. What not to do. And this is tough. We see, and I've seen, and I'll keep using that expression because I've seen a lot over the past 25 plus years where if one of the spouses has the dementia, the caregiver gets very, very frustrated. And it's not good. It's not going to be a good outcome. And I know it's very, very hard to see your loved one decline. And when you ask them, "Hi, Mary, let's go to the grocery store now, and we're just going to go out and pick up a few things." And Mary says, "Well, what grocery store? What do you mean we're going to pick up?" And the caregiver says, "What do you mean? We just talked about this." All that does is create a situation where the individual with dementia becomes very, very frustrated, becomes very anxious, and again, it can turn into a not real good situation. So, don't argue. And again, I know it's very hard, but try not to argue and utilize slow speech to help that person. Hey, don't you remember it's called Safeway? We used to go there all the time. Remember they have that big picture right when you walk in. Oh, right. That's how you want to approach it. Do not give orders or talk down to the person. It's another one. It's not going to create a healthy environment. Do not ask questions that require remembering facts. So someone with dementia are not going to remember the short-term details of something. If a relative was over the night before and you asked, "Hi, Ruth, do you remember Jeremy was with us last night?" "No, I don't remember Jeremy being here last night." "Well, sure you do. You remember Jeremy being here." Someone with dementia may not. And as a caregiver, most importantly, don't take the comments personally. That is a big one. It's very tough, and it's hard to swallow. But a lot of times, individuals with dementia will say things they don't mean. They can't control it. They're not the same person. And that's dementia really, I look at it, it robs someone of their character and their personality. It really does. It takes over. And that person who we all used to know is no longer there. And that's the very hard piece of this, is individuals with dementia, unfortunately, because of the process, the disease progression, they're not the same person. It's so hard to watch. Let's talk about some techniques. Definitely you want to apologize. Okay, I'm sorry, you don't remember, or you can't recall that grocery store, but let's talk a little bit about it. And I'm sorry, I'll give you a little bit more heads up beforehand before we go. And then also agree. A lot of times, just go with it. So there's a lot of times where you'll, as a caregiver, you may find a question is posed to you. Stacy, what do you think about the workers in the backyard? And there's no workers, realistically, there's no workers in the backyard. And as the caregiver, a lot of times you can, if you say, what are you talking about, Stacy? Really, what are you talking about? That's not the right approach. What you want to say is, oh yes, they were back there the other day, they may be coming back, and we call that therapeutic fibbing. You just go with it. So the resident over at Carroll Lutheran Village that thinks I'm an FBI agent, I go with it. Now, I'm not impersonating an FBI agent, but I just go with it. And sometimes that brings a lot of levity to the situation. So therapeutic fibbing is a good one. Validation therapy. It's always good to validate the time and place. If you're caring for someone with dementia, it's great to have a big calendar and a big clock so they can look at it, and then you can go and show them the time and the place and the season. That brings joy to the individuals with dementia. So validation therapy is also very, very important. Let's go to the next page. So we talked a lot about individuals with dementia, but let's talk about the caregiver being a caregiver and how important it is to take care of yourself. Because if you go down as a caregiver, it's going to make the situation, like I said earlier, a lot more unmanageable. So being a caregiver can be extremely rewarding, for sure. But it can also be very overwhelming. Caring for a person with dementia takes time and effort. It can feel lonely and extremely frustrating. You may even feel angry. And I know that you hear a lot of, why my husband, why my wife, and you get angry as a caregiver. But and that's all part of kind of going through that journey. You may even feel, like I say, you could feel angry, which is a sign you're trying to take on too much as a caregiver. It's important to find time as a caregiver, and I know it's easier said than done, but I've seen it. If a caregiver takes advantages of those resources and follows a plan to take care of themselves, it is really going to help the situation. And these are some tips, some very popular tips that I'd like to go through. ask for help. As a caregiver, ask for help. This could mean asking a family member to come over, give you 10 minutes to go for a walk while they spend time with the spouse who has dementia. Eat good foods, which can, again, this all goes back to the whole being healthy as a caregiver. And it's again, food is very important, and so is being hydrated. There are a lot of groups out all around because of our aging population and more diagnosis of dementia. There are a lot of caregiving groups, support groups. The best thing you can do is go, because you will be in the room with individuals who are going through the same thing that you're going through, and it will be able to help them. Help yourself. Also, you'll be able to help them as well, because everybody shares good tips and good best practices. And a lot of times people walk out of those support groups feeling like $1,000,000. They're reset, they're energized. They know that they're not alone. And I think going to those support groups are very, very beneficial. Take breaks each day. Take a break. So if you're a caregiver and you know the routine of the person who you're taking care of, and you know they're going to go and take a nap from 2 to 4, do something for yourself. Now it says here, make a cup of coffee or make a cup of tea, call a friend, but do something during that time frame. What's that game everybody's playing now? Wordle? Do a Wordle. And in fact, I saw on the Alzheimer's, I think it was the Alzheimer's chapter, national chapter, where it says doing Wordles as a caregiver is very therapeutic. Again, spend time with friends and keep up with your hobbies. If you have a hobby, again, easier said than done, but if you do have a hobby, try to stay with it. Get exercise as much as you can. Going for a walk, going for a run, doing yoga. Anything exercise, anything that's making you move as a caregiver is going to be beneficial. There's also practicing medication. There's a lot of really good benefits from meditation that you can certainly talk to a clinician about that helps manage you as a person and what you're going through. And also, just remember also, it takes a toll on, as being a caregiver, physically and mentally. So take advantage of those resources by health professionals to help you cope with the stress. And talk to your doctor or your physician about what those options are. So most importantly, you got to take care, as a caregiver, you have to take care of yourself. And let's go to the next page. So I talked a little bit about just some details, what we just talked about, taking care of yourself as a caregiver, eating, exercising, spiritually, what you can do to help yourself as a caregiver. But let's talk about 5 kind of external ways and resources that can help you as a caregiver and your spouse or whomever you are taking care of. Respite care. Who knows what respite care is? Anyone? Okay, so it is a underutilized service that I think that as a spouse or a caregiver, you don't really think about, because you don't want to disengage totally with the person who you're taking care of. But there are a lot of programs and a lot of senior living care communities who offer respite care. So that's respite care for your loved one. A lot of times assisted livings will offer 2 weeks or a week of respite care. And respite care is a good thing. Number one, gives the caregiver a break. You're able to, I used to see a lot of respite care was a big boom in the industry right around the holidays. Before, or like right during or right before the holidays, respite care was very popular, it still is, where the caregiver can actually go out and do holiday shopping, go to functions, see relatives, and just know they have a peace of mind that their loved one is being taken care of in an assisted living. So respite care programs are very popular. Popular but underused. And if you are thinking about respite care for someone you were caring for, it's a good thing. It's a good thing. But there are also adult programs, adult day programs for individuals with dementia. You're starting to see a lot more of adult day programs that are specific for residents or individuals with dementia. And a lot of those programs start at 8 a.m. and end at 4. And what those programs do is keep your loved one or whoever you're taking care of engaged. They may do 5 hours of Wordles, who knows? But they keep that person engaged throughout the day. Gives you a break, but you still have that interaction with the loved one who you're taking care of. There's a couple types of adult days. There's the medical, and then there's the social. And the social is really geared more towards early stage dementia. It's a lot of social activity, cognitive engagement, and those types of programs. There's quite a few just in this area I know of myself, and I didn't list any because I wanted, obviously I will make myself available through email and phone to help you try to find one that, or provide you some guidance on if you're interested in an adult day program. Also, a resource to look at is having an in-home aide. There are a lot of small or middle-sized or even large companies that offer in-home. What does in-home mean? They will come in, they will help your spouse or the person you're taking care of get dressed, they'll help cook breakfast, they will be a companion, and it will help you as a caregiver find some time for yourself. Gives you a little peace of mind, but there are home health companies that offer this. Hospice care. Now, a lot of people, when we talk about hospice, everybody, their first thought is, this is terminal, this is the end. Not always the case. Hospice is can be used in home as well. If somebody is declining and they don't have the ability to thrive, that means not eating as much, not as active, and hospice will come in and actually help with the big picture, physically and cognitively. And they will help with medications, they will help with activities of daily living, getting dressed, showering, bathing, and also spend time with you as the caregiver, helping you through the situation. But hospice care is not specifically for somebody that is very close to end of life. It really can be utilized as for someone who is, yes, declining, but doesn't have the ability to thrive. And there are residents, there are individuals that have been on hospice. They make a comeback. They're on and off hospice probably 10 times But it's those little interventions like hospice care that can really make a difference. And I think I mentioned before about dementia support groups. I think they are one of the most valuable resources around. And there are dementia support groups that are now so specific even to the types of dementia that are very helpful for caregivers. The last piece is also as something to consider is assisted living. And there are assisted livings all around that have secured units or sections in the assisted living that specifically are geared and developed for individuals with dementia. So their staff is trained to deal with dementia, as we were talking about with the communication. So there are a lot of assisted livings out there that just do dementia specific. And at that there is a point in time where you as a caregiver, it can get a little much. And the ability to not help your spouse or the individual you're taking care of with getting dressed and utilizing the bathroom and those individuals who aren't eating, it does. Unfortunately, there is a point in time in the stages through dementia where that happens. And there are, like I said, there are a lot of places out there that you can engage in conversation. They will walk you through it of how they're going to take care of your loved one. And again, very beneficial. It gives you a peace of mind. You can go there every day at 11 o'clock and see your loved one, and they're dressed, they've eaten, and it gives you a peace of mind. So there are a lot of different options out there to consider when it gets to be too much. So Respite Care, Adult Day, In-Home Health Aid, Home Health, Hospice Care, Dementia Support, Communities, and also assisted livings. So those are some resources to think about. So that is actually the last page on the presentation. I would like to open it up for some questions.
My name's Ginger. My sister, who lives in Florida, was just diagnosed with dementia 2 months ago. What are the chances that I could get dementia because she has it, as I get older?
So,
the little things that you're saying in the first column, yeah, that happens occasionally with me even now because I'm 69 years old. But there's no one else in our family who's ever had dementia or Alzheimer's. But I just wondered what are the chances of?
There are dementias that run in the family. Just because your sister has it doesn't mean you're going to get it. So the question was, if your relative, a close relative has it, are you going to get dementia? Not necessarily. Not necessarily. What to look for in those types of cases is if your mother had it or your grandmother had it, and so if it's running through your family generationally, there is a possibility.
And that's not the case. So like
Right.
she's the first one in the family, and I'm so busy. I'm not that if I ever slow down enough to get it.
Right.
But I was just wondering about that.
It's something to keep an eye on, and something when you go and have a checkup with your physician, you might say, hey, my sister just got diagnosed, and I just want to keep an eye on it and let you know. But no, not necessarily. How about some more?
Are there tests for dementia, or if it is a genetic form, are there tests that will indicate that?
You know, I'm not 100% on like a blood test or a gene test. I'm not 100% on that. Things change so much. They can run a battery of tests, like a PET scan.
Yeah, they did that for all kinds of
Right.
stuff.
They do something called a mini mental test, where they run through a battery of questions and it will give them a baseline of where that particular person is on how they answer the questions. A PET scan is the biggest one. And I believe on a PET scan, you're actually able to see if they have, remember in the beginning I talked about with Alzheimer's plaques and tangles? Sometimes you're able to pick up on plaques and tangles in those PET scans. But again, I think what they're doing now, they're utilizing PET scans, like verbal tests, to get a baseline to really help diagnose. And I think in the past also, the only true way to find out a while back if somebody had dementia was doing an autopsy, where they would actually examine the brain and they were able to see how it affected the brain. And it's tough to look at because there are pictures that show how somebody's brain shrinks who's had Alzheimer's or dementia. But I think they are getting better with piecing those things together, looking at family history, PET scans. There's also a test called a Benz Test. I don't recall what the BIM stands for, but it's one of those, who's the president of the United States? What year is it? Where do you live? Those types of things. And I think all those together, along with the total picture of your health, will help really diagnose if you have some type of dementia. What other questions? I know there's got to be more.
I have one considering finances. If any of the different offers that you mentioned would give any financial support, because a lot of times you'll find someone or some group or department that will do that. The first thing they want to do is start working on the value of their home. They'll say, well, you don't qualify because your home is worth so much and you'll have to dissolve the value of that. And that's a lot of concern for many people.
Yeah. So the question or the statement was really about financial resources. I'm assuming, sir, you're talking about if you're going into like an assisted living or utilizing home health. So there are a lot of situations. Assisted living, it is not covered by Medicare or Medicaid. It's all private pay. But there are certain interventions. There's long-term care insurance plans will sometimes cover it. A lot of times for home health, we'll cover it short-term, but not long-term. There's a specific benefit if you were in the military. And if you were in the military for a certain period of time, you're able to submit an application and you get a certain amount of money towards your care. So if somebody's in an assisted living or any skilled nursing center and they're paying privately for those services, that benefit through the government, if you were in the military, a lot of people don't know about the benefit, but there is a benefit out there. And there are elder law attorneys that know about all those ins and outs of getting additional resources, so you don't have to sell your house, or you don't have to drain your bank accounts or your savings. But it's good to talk to the right people, and the right people are those people in your Rolodex, I call it, your attorneys that you deal with, your accountants, And there are all those individuals are getting a lot more versed and helping in these situations to help their clients with resources so they're able to accommodate and help financially. There are, just kind of going back to skilled nursing is paid by Medicare up to a certain period of time. It could be 2 weeks, it could be a month, but then after that, after your Medicare days run down, then you'll go to private pay. But not to get too deep into this, there are, when you first come from a hospital normally, and you go to a nursing center, normally you're going to be on Medicare for a certain period of time. And I think individuals have, I think it's 100 days a year of that benefit to use, but it's only in certain periods of chunks of time that you can use it throughout that year.
How about respite care? Is that Medicare?
Respite care would be under assisted living, or yes, it would just be under assisted living. And a lot of times with respite care, it is private pay. And there are some long-term care policies that help with that. But normally a lot of times with respite care, it's done on a per day amount, all-inclusive amount. So for example, it could be $350 a day and for 2 weeks. And a lot of senior living providers really try to make it as easy as possible. So it is all-inclusive and not all these a la carte type of options that you'll see sometimes if you're looking at assisted living. But respite care is normally a one price for a certain period of time, but it is private pay.
There's lighter sides. My mother lived with us for 4 years in dementia, and she would, we were not arguing, because I couldn't prove it. I mean, just why would it get so? I wouldn't argue with her. But one day she said, there are 4 Anchorage Alaskas, because my brother and sister live in Alaska, and their family was with them. And I said, Mom, no, there's one. They all live in different parts of Alaska. And she said, no, there are 4 Anchorages. So I thought, I can prove this. I got out the map. And I said, Mom, see, there's 1 Anchorage. She said, that must be an old map. So I thought,
But that was good. And I bet it wasn't an argumentative situation. You did what you just did was validation, and also diffused a situation. And like you said, you were getting ready, it seemed like you were getting ready to get into an argument, and you did the right thing, but you did validation therapy, which is great. And sometimes that happens because the last thing you do want to do is start into a rebuttal, into an argument with someone with dementia. Nobody's going to win in those situations. That's why I said therapeutic fibbing is good, and what you just did in terms of validation is even better. Somebody in...
My concern is sometimes the medications are on the statin drug, and the information that you get on these drugs, it says it can cause confusion,
Sure.
memory loss, all kinds of things like that. So we had mentioned a couple years ago to our doctor. He didn't seem to quite comprehend how we were feeling about that. But we heard, other things about that, and so we're very concerned about some of the drugs we're on. So that would make us look like we're, and it says feeling tired and weak.
Right.
And all these things that kind of we're feeling right now.
Right.
Like the memory loss and things that we're not able to keep up, and we're wondering if these medications are just kind of robbing us of their memory.
It could be, but just a lot of times, if you are on a medication, and again, I'm not a physician, but just through experience, there are a lot of new medications too that can cause memory loss, confusion, and the best thing to do is make sure you have that information before you go on that medication. Make sure your family knows, and make sure whoever is taking care of you knows. Make sure you're having a good, healthy discussion with your doctor. If you're feeling like that medication is really affecting you in those areas versus helping the condition, talk to your doctor, and they may want to change it. But yes, there are a lot of, and I don't, knowing obviously that there are so many medications out there that will do that. A lot of them are short term until it gets to a certain point in your system. You do see a lot of new medications being introduced to people. Even myself, you take a new medication for 2 or 3 days, you feel loopy, you can't remember things, you're tired. But eventually, once it stabilizes, it does go away to some degree. But if it's constant, continuous, then you need to have a conversation with your doctor. Is that you have to weigh the benefits of that medication. More questions?
So if assisted living is private pay, do assisted living facilities have a process to evaluate someone to say this person is appropriate to be moved into assisted living or is not? They're not their condition or whatever. It's not appropriate. Assisted living isn't appropriate.
Absolutely. And that process, that evaluation process, is done through a couple approaches. Number one, it's done through your physician, and a lot of times that physician will say, I really do think your mom is a good candidate for assisted living because they're not able to take their medications on their own anymore. They're not able to dress themselves 100% anymore. They're not able to fix their own meals. So I would say your mom is a good candidate for assisted living. So whatever the provider, that assisted living will actually collect all the medical information, and they will review it, and they will actually come out and do an in-person evaluation in person. And they will make an assessment at that point if they're going to be able to, they want to be able to appropriately care for someone. They don't want to take somebody in that is too heavy care. And when I say too heavy care, a lot of times what we see is a resident will come in assisted living, and when they come in, they're able to transfer. They're able to, actually get out of the wheelchair, transfer to do their own toileting. They're able to actually use a walker or a assisted device, which is great. But over a period of time, if somebody is at home and they were doing that at home, and then now they're in a situation where they need a 2-person transfer, that's actually not assisted living. That would be more skilled, long-term skilled nursing. But they do come out, the assisted livings will come out. They'll have a clinician that will come out and actually do the assessment, get all the medical records from the physician, and that way they make a determination. But with assisted living, you have to keep in mind, with assisted living, they can only take up to a certain point of care. And if they're too heavy care, as I mentioned, bedbound, really not able to do anything for themselves, they really need to be in a higher level of care, and that would be in a long-term care skilled nursing facility. What other questions do you have? Well, I really hope this has been helpful. I hope these were very general areas that we went over. I think it looked like just watching people's facial expressions in the audience today that some of you have gone through these situations before. And I will certainly give my information to Ann or whoever, Stacy. I will always make myself available to help you answer questions and find a resource for you, because there are a lot of resources out there if you're caring for someone with dementia. So I thank you very much. Have a great afternoon.
Thank you.